Good morning again. This is Megan Griffith from the Missouri Hospital Association, and it is 10 a.m., so that is our original start time. It looks like we still have quite a few joining currently, so we will take just a moment to let a couple more get signed on. For those of you that have just joined, you'll see the welcome screen displayed, and it's really important to note that if there are several of you listening in at one location, we would like for you to send us an email. My address is on the screen. It's mgriffith@mhanet.com. And just let me know who's listening in with you so that our records show an accurate count of attendees for the event. It's also good to note that attendees are joining in presentation only mode, so it's listen only mode. You're not able to speak at this time, but as we get further into things, we can unmute as we go. So again, we will start as quickly as we can. We're still letting a few log in currently, and I'll let you know when we get started. Thanks.
Hi, is this, can everybody hear me? Anybody?
Hi, so this is Megan from the Missouri Hospital Association. All attendees are in listen only mode currently, but we can switch that whenever we need to. In the meantime, I will go ahead and switch our screen so that you can take over.
Great. Wonderful. All right. So, hold on one second. I just got to close out all the PHR that I have around sitting around. And let me share my screen. Hold on one second. There we go. And all right. Can people see my screen? I just want to make sure that people can actually see what I'm presenting.
Yes, your screen is displayed and it looks like we're good to go.
Great. So, hi everybody. I'd like to introduce myself. I'm Kevin Choi. I'm one of the assistant professors of medicine in the Division of Infectious Disease at Washington University School of Medicine. I'm also co-director of the Antimicrobial Stewardship at Barnes-Jewish Hospital. And I would like to welcome everybody to this first kickoff call for the Missouri Antimicrobial Stewardship and Educational Collaborative, or MASEC. Believe me, we tried to find all sorts of better acronyms, but that one we kept coming back to that one over and over again. This educational collaborative is a joint effort between the Missouri Department of Health and Senior Services, the Missouri Hospital Association, and Washington University School of Medicine in St. Louis, to try and disseminate antimicrobial stewardship information throughout Missouri in a free and open format. All right, so I wanted to close a couple of things. So as I said, this webinar is supported by the Department of Health and Senior Services with help from a Centers for Disease Control and Prevention grant. And I also want to say that I have a personal interest in making sure that antimicrobial stewardship in general is a successful enterprise. So I am a career hospital antimicrobial steward. I've been doing this for, oh my God, years now, which is slightly shocking to me because I don't feel like I'm that old. And I'm also a recipient of occasional medical care. Like I think all of us are. We want to make sure that our medical care is as safe as possible. I don't want to get resistant bacteria when I go to anybody's hospital any more than any one of you. And I think that's the goal of antimicrobial stewardship, is to make sure that that medical care remains as safe as possible and as good as possible as it possibly can be for the foreseeable future. I'm also a collaborator on an investigator-initiated study of candidal infections funded by Astellas Pharmaceuticals, but thankfully we're not talking about candidal infections today. So this is going to be an interactive session. So MASEC uses the Poll Everywhere website for audience response. If everyone could please log in you can even log in on your phone. Just go to this website, pollev.com/MASEC, to log in and start to provide answers. I want as much audience response as we can possibly get, because we're trying to make this a back and forth process. Please just vote yes to make sure that this works for you. Responses to surveys and polls are going to be recorded and used to generate improved future webinar content. So just be aware that don't put like loss of PHI on anywhere. So great, I can see everybody's logging in. We've tried this many times. It's a generally easy process. Oops, we lost somebody. Yes, you can accidentally reverse your vote. So great. I think we have around 50 people on the call today, so I'm hoping to get up to a good percentage of that. If you can't, don't feel bad, but it will decrease your ability to sort of voice your thoughts. So we want to have everybody be able to talk about what their concerns are and what their interests are with regards to stewardship. Nice, almost halfway. I'm going to wait for just a couple of more seconds to get everybody, as many people as possible, able to answer the responses. So 21, can we get up to 25? Oh yeah, oh no, wait, somebody didn't want to. Awesome. Okay, once we get to 25, I think I'm going to keep going. You can always still log in to the Poll Everywhere website, and then you'll be able to answer further questions that are going to be coming up during this webinar and during the webinars to come. So the MASEC, you might want to bookmark this website, because the MASEC Poll Everywhere response site is going to be used for all our future webinars and conferences. So we're going to try to make this a pretty consistent theme. Being interactive generally makes these kinds of educational webinars more helpful for everybody, and it also allows us to figure out what's working and what's not. Okay, I'm going to keep going. So part of this kickoff webinar is to just introduce the MASEC team, the core Washington University team that sort of leading the coordination for the MASEC program. So there's myself, and that's my, this is my gloriously handsome face, as well as my co-director of stewardship, Mike Durkin. And then our key point person is going to be Erin Ratmiel. So Erin is a stewardship pharmacist with extensive experience, especially in stewardship in small community settings. So we know that for the most part, that's going to be the majority of the facilities in Missouri and in that are involved in MASEC. So we wanted to have somebody with extraordinary experience in this, and Erin is very well versed in both the approach to stewardship and all the kinds of problems that we can find there. Tracy Habrock-Bach is our project coordinator. She's going to be, you may get occasional emails from her or just questions or concerns. We have involved in the process a number of physician subject experts. So, and these are because nobody knows everything about stewardship all the time. I think the goal is to have as much expertise as possible involved. And one of these people is Jason Newland. And Jason is an ever-present force, almost a natural, almost a force of nature in stewardship. And I think almost everybody recognizes him. We also have Kayleen Matar, who's an expert in antimicrobial stewardship in the community and resource limited settings, and Jason Burnham, who is one of our rising experts in stewardship and multi-drug resistant organisms, including infection prevention and multi-drug resistant organisms. We have help from WashU's Dissemination and Implementation Research Center, or the DIRC, to help make sure that we're doing this as effectively as possible, so that we're disseminating information for use for all of you as in a way that is as digestible and as utilizable as possible. These our members from the DIRC are Ginger McKay, Megan Pilar, and Stephanie Mazuka. So let me go to the next. So I would be amiss by not mentioning the reason why I think many of us are on this call and many of us are involved in stewardship, and that is Missouri Senate Bill 579, which was passed in 2016 and mandated that all hospitals and ambulatory surgical centers in the state of Missouri establish antimicrobial stewardship programs. And it also requires National Healthcare Safety Network, that's a branch of the CDC, reporting of antimicrobial use and resistance by the time stage 3 of CMS's meaningful use requirements went live, which I believe at this point is now the beginning of 2019, though please correct me if I'm wrong on that. Now, the problem is that stewardship is a per hospital issue, and Missouri has 164 hospitals spread almost evenly throughout the state. Yeah, there's a little bit of a cluster over here in Kansas City and Missouri and St. Louis, but really we're everywhere. So if every single one of these hospitals is trying to build successful stewardship on their own, it can just be a crazy mess. And so what our goal is to try to help everybody be as successful in stewardship as possible. And so what I'd like to do next is a poll, and this is a word cloud, to basically get what people's idea of successful stewardship is. So I'd like to ask everybody, what are the words that you associate with successful antimicrobial stewardship? Just type down whatever's in your head, as long as it's not PHI. So great, we have collaboration. So I'm going to give this a couple of seconds just so that we can start getting people's thoughts. Wonderful. People really like collaboration, and it absolutely is. Right. So seeing a strong theme here. So clearly collaboration and its corollaries, multidisciplinary. I think I also saw teamwork in there somewhere, are huge themes in stewardship. Accountability, a judicious use of resources, which I think is actually, that whoever wrote that, that's incredibly keen there. Reducing resistance, I think that's the goal for all of us. In resistance and safety, incredibly helpful. There is, of course, savings too. I think we'd be amiss in saying that this was outside the realm of stewardship. Best practices, leadership, the antibiogram, which is a core component of what we do, physicians, pharmacists, and let's see what else we've got. Accountability and being evidence-based. So there are a couple of pretty strong themes here. So that there needs to be leadership. It's very contextual. It requires a lot of education, and of course a lot of teamwork. And the goal is to make our patients safe, and also perhaps decrease costs along the way. So I'm going to, if anybody wants to get in and get anything in right now, I'd do it now, because I'm going to go to the next slide. But absolutely, all of these things and more are associated with successful stewardship. When I was thinking about this, I tried to distill this down to just a couple of items. And what I was thinking was that successful antimicrobial stewardship really has to do with experience in implementing stewardship, because oftentimes it requires a lot of teamwork and it's hard to build teamwork. Also experimentation. There are things that work and things that you'd think would work that don't. As we said, there's a lot of evidence that's required for stewardship, a lot of expertise, and so subject matter expertise is very helpful. And then institutional support, building that kind of collaboration is also incredibly important. And the problem is there's a lot of hospitals, and it's really hard to get all of even these three parts of successful stewardship, it's hard to get them all together at every single one of these hospitals. And so part of what MASEC is designed or is intended to do is to try to help make that, perhaps you could call it a weakness or difficulty, that 164 hospitals, into a strength, to help institutions with perhaps larger resources or maybe more experience in stewardship, disseminate that experience and disseminate that knowledge of stewardship to all the other smaller hospitals, and to also take the experience of smaller hospitals and help share them among other small and large hospitals if it's working. Because we need dissemination of successful practices. 164 hospitals all trying to do different things. There are going to be a lot of things that work and a lot of things that don't. And we'd all like to do the things that work. We'd also like to help the DOH assist where it can. So the Department of Health realizes this is an incredible challenge and an incredible, I think, goal that the state has set for us that we want to be able to meet. And part of the point of MASEC is to help them figure out what are really the pain points and where the DOH can really add and assistance to help in success. The program structure for MASEC as it stands right now is a monthly case conference, and we're going to have an example of what this is like today, which is a case conference and didactic webinar. And these are going to be short or relatively short conferences discussing real life cases. Special topical webinars, and these are going to be longer, hour-long webinars, topical facts and other literature that you guys can use to support your programs, and a staffed Missouri Stewardship or MO Stewardship at worcester.edu email, where you can send a single centralized point of contact where you can send questions, topics, and challenging cases, and get ideas on how to address them. So just a little bit more about the monthly case conferences. We're really hoping to get cases drawn from our collaborative members. So things that are, just bugging you, things that you're not sure if you made the right call. And by the way, I think that happens to all of us all the time. I'm always worried that I haven't made the right call or there's additional nuance that I haven't thought about. We want these cases. We want to be able to discuss them and have you guys hear from all these other experts so that you can support your case better and make sure and feel supported in your decisions. We're going to make them interactive, just like with the word cloud before. The conference structure is going to be very straightforward. It's a presentation of a case. We're going to discuss the approach and issues that people identify. It's actually not just issues identified by content experts, but we'll discuss issues and the approach with content experts. We'll have a Q&A with collaborative members trying to answer as many questions as possible, and then a short didactic on the topic, and then we'll provide useful handouts and educational materials based on the feedback and the questions that we receive in these case conferences. We'll have special topical webinars, and so these are hour-long seminars focused on a specific topic of significant concern and interest. I think, in particular, the NHSN Antimicrobial Use and Resistance Module mandate from the Missouri legislature is a concern to many of us. Other mandates from government and accrediting bodies, and then stewardship stewardship in the context of highly resistant organisms, and then stewardship in small communities and resource-limited settings. Because I don't think it's difficult to do the job when the people who are telling you how to do the job maybe are all from tertiary academic centers. So we are trying to get a lot of experience from this. Now, I'd like people to sort of sort out what they think, what their interest is in these topics. These are what we have right now, but in the Poll Everywhere poll, you can just shift around the priority of these topics, and we'll try to focus on the ones that you find higher priority. So if people want to shift around and vote, that's great. If I'm going to give this a couple of seconds just to see what people are thinking. If this one doesn't work, it's possible. This is sort of a more unusual kind of poll. Hopefully. Oh, there we go. Nice. All right. Okay, so it's clear. The numbers are clear. People are very interested in stewardship in small community and resource limited settings. And so I think we'll probably try to prioritize this one first, if we can. And then, of course, there's the NHSN antimicrobial and resistance reporting, which we're mandated to worry about. So we're, of course, worrying about it. And then maybe lower down on the list are stewardship in highly resistant organisms and mandates from government accounting bodies. So next, I'd like to know, I'd like to go on to our next sort of component of the MASEC program, which is FAQs and informational literature. We're going to be emailing these out, and so these are sort of handy and expert vetted summaries of some critical topics in antimicrobial stewardship. They're going to be emailed out, but they'll also be freely available at our website, which is still in development, but we're going to be sending out the website address once it's ready to go live. It'll be focusing on topics discussed during the webinar that are requested by collaborative members. And currently we have available What is Stewardship, trying to help you explain what we're doing to leadership and why we're doing it. Double coverage with antimicrobials, because that seems to be a very common theme among the cases that we have discussed in the past with other hospitals. And then the future topics are really up to you. You get to choose what you'd like us to talk about. And so that going on from that, that's exactly what we would like to hear. So with this poll, you can write down anything. You can write down any topic that's of interest to you, and we'll collect the responses. And if there are a lot of similar responses, we'll probably try to target that. So resource sharing, so that's a great one. Mechanisms of resistance, how to get resources, and that's a big concern. So, you know, part of the thing that we're trying to do is not just make this a scientific lecture. Scientific lectures are great and they're very useful, but what we're also going to try to help with is techniques on trying to get more buy-in and more resources from where you can get it. So Q&A sessions, nursing education tools, new antibiotics. There are a lot of new antibiotics. Facilitating physician education, that's a tough one. Ways to educate. So education seems to be a pretty strong theme, and that's what those handouts are supposed to help with. So case examples, clinical education. I see a strong education theme. Penicillin allergy testing, that's actually a hot new topic in antimicrobial stewardship. Training, so more education. Success stories, we definitely can do that. Quality reporting. Outpatient stewardship, this was the tough one. Certification and training for pharmacists. So we can, any others where I'm going to jump from this poll soon, so I just would like anybody to get any ideas here as they can. There will be more opportunities to write down topics of interest at the end of this conference. There'll be a little bit of a survey, so you can write down anything that you want there as well. Protocol structures. So yeah, so how to set up these protocols to work effectively. Data collection tools. We'll try to answer as many of these as we can, though clearly education and training seems to be a pretty strong theme right now. So, one thing I wanted to emphasize is the Missouri or Mo Stewardship at Westall.edu email. So we created this to be a central point of contact for stewardship or collaborative aimed questions. I do want to remind everybody, this is not a consult email. It's not really for urgent or emergent clinical questions. And the only reason I emphasize this is I don't want your patients to get hurt waiting for an answer from us. We'll try to respond as quickly as possible, but it's not a real-time service. So reasonable topics to email, though this is definitely not a limited set, is recommendations on approach to specific issues that you're dealing with in stewardship, challenges that you're facing, topics for discussion at this kind of webinar or future webinars. Challenging cases, we're always interested to hear challenging cases of stewardship. And it doesn't just mean challenging from a biologic standpoint. This can be challenging in in the interpersonal or administrative realm as well. Scientific questions, of course, we have a lot of experts available to us, and so we're happy to answer scientific questions as much as we can. Help finding additional resources and assistance and advice from other collaborative members. We're trying to figure out a way, though I don't think we've got it set up right yet, so that collaborative members can sort of chat amongst themselves using the resources of the MASEC program. And then requests for template materials from pharmacists. So, like people noted, protocols for for specific things like IV to PO conversion, order sets for common conditions. It's going to be staffed by one of our pharmacists. So it's going to be staffed by Erin, who's very well experienced with community-based stewardship. So we're hoping that she can answer most of your questions sort of pretty quickly, though we're happy to discuss it internally and get additional answers out to you as soon as we can. So I wanted to end this kickoff call with an example of the kind of case discussion we're gonna be dealing with. So this is an example, a real example with some slight modifications, drawn from a real case at one of our community hospitals. And this case dealt with an 82-year-old woman who came to the hospital from home complaining of sudden onset abdominal pain. She wasn't febrile, she was normotensive, not tachycardic, but she did have a high white count. She had a white count of 20.1, 16% bands, and an elevated creatinine. It was 1.4. I'm not actually sure if this was normal for her or elevated. She's a little bit on the light side, 107 pounds, 48.5 kilograms, and her CT abdomen showed a thickened sigmoid colon with diverticuli and a possible enhancing fluid collection along the sigmoid colon. She was started on IV Vanco, IV Meropenem, and IV metronidazole at these doses. And so that's where the stewardship team had a question. So what stewardship issues do people see in that case? Oh, shoot, I should have put a summary of the case there. So I apologize. In the future, we'll have a summary of the case alongside this poll. Sorry about that. Right. So renal dosing and double anaerobic coverage. Anybody else got any thoughts? I apologize. I sort of ran through that kind of fast. And let me see. I'm going to try something which may or may not work. I'm going to flip back to the case just so people can reference it for a second. And then I'll go back to that poll to see what other people have, what other ideas people have. Okay, I'm going to go forward now. Let's see if anybody else has, if people have other thoughts. So renal dosing being one of them, absolutely. Improper empiric therapy, over coverage. That's a good thought. Give it another couple of seconds. I wish I could get the Jeopardy song going, but I think that probably is a little more complicated than it should be. Okay. We're going to time out, but right now the responses are improper empiric therapy, renal dosing is clearly a concern, and double anaerobic coverage being another concern. So the way that we're going to try to have this expert discussion go is we're going to discuss, I like having frameworks for the way that we evaluate cases. And so what we're going to have is a discussion of the choice of agents, any issues with agent pharmacology, the approach to the physician, and so, there may not be much with this case because I didn't describe the issues with the physician, but the approach to the physician, the duration of therapy, and then any systemic issues or solutions that might be relevant for this case. So, as many of you pointed out, the choice of agents in agent pharmacology are initially on first glance may seem sort of reasonable, but on second thought, they probably aren't. So vancomycin is probably not needed. Why? Because this person has a burst diverticular, or a diverticular abscess. They probably don't have MRSA or enterococcus really, or at least not enterococcus that is resistant to meropenem. And so they probably don't need vancomycin. Meropenem will cover both the gram-positives and gram-negatives that are of concern here. Meropenem and metronidazole, as you guys all pointed out, it double covers anaerobic bacteria. And we're going to talk a little bit more about this because one question is really, okay, so they double cover, but isn't that better? Isn't that a good thing for you to have twice the amount of killing power? And I'm not sure if the data really supports that. And the last thing is that meropenem may be overly broad. It really depends on the patient history, but if you have a person coming in from home with diverticulitis and maybe a burst diverticular abscess, they don't really need meropenem. You're not really thinking that this is a person with a high risk for antimicrobial resistant organisms. And so something lower like piperacillin tazobactam, or I think sometimes ampicillin sulbactam or Unicin, or so that's Zosyn and Unicin for people who are used to thinking about the trade names. Those might be better agents than meropenem, just because the carbapenem, if you don't need to use it, really shouldn't. There are, like people noticed, the renal adjustment wasn't done properly. So vancomycin was overdosed, not just overdosed for her renal function, but overdosed for her weight as well. I sort of added a little bit of a trick there. She's here. I'll jump back. She's too light. At 15 milligrams per kilogram, should be around 750 milligrams of vancomycin, not 1 gram. Though everyone loves using 1 gram. And the meropenem also, the frequency and the dosing are too high. So because she's got AKI, I think her creatinine clearance, we didn't get the weight, but it would probably be somewhere around the 20s to 30s. So there are really no, because we didn't discuss the physician, there are really no approach issues with her. The one thing is that many times physicians, especially empirically, are very reluctant to change broad empiric therapy, and it sometimes is not worth the sort of anger it engenders to try to force the issue immediately. But oftentimes a bargain can be struck that, if they're doing okay or if they don't deteriorate, I strongly recommend and try to get them to agree to de-escalate within a certain amount of time. So, oftentimes we have people agree that they'll stop vancomycin at 48 hours if they don't find MRSA anywhere, even though the MRSA risk for this person probably isn't that high. Meropenem should be de-escalated if the patient's improving. Sometimes you can get them to switch to oral agents, or even just stop. Especially if it's been 3 days and they've been on meropenem and they're doing great, sometimes you can just stop right there. In this case, their patient has an abscess, so probably oral agents is probably a better option than just stopping antibiotics altogether. But it's really very dependent on the patient issues. There are some systemic issues and solutions that you could probably draw from this case. So one is that the physician clearly was sort of just making up the regimen out of their own experience or perhaps out of previous cases. And one way to help them choose the right antibiotics is with standardized treatment guidelines or order sets. So if you had a treatment guideline recommendation sheet that identified your hospital's preferred medication for simple diverticulosis or diverticulitis, that would help them identify that maybe they don't need vancomycin, maybe it's just Piptazo, or maybe it's just ceftriaxone and metronidazole. And order sets make that even more convenient, though there is some debate over whether or not this is actually more effective. And then renal dosing guidance and standardized adjustment could help with these pharmacologic issues that we've identified here. That automatic conversion. So I know many hospital systems have vancomycin dosing adjustment and management by the pharmacists themselves, or standardized guidance either in the electronic medical record or just with a call. So these are the kinds of points that we're going to be identifying for these various cases. And that's why we'd like as varied a distribution of cases as possible. The more we can, the goal is that the more cases that we can discuss, the more sort of these nuances we can identify. Part of this is because it's just, if you read all of this in a didactic lecture and just read it in a textbook, it's not nearly as alive and it's not nearly as memorable as it is with cases, with real patients. So just to demonstrate what the didactic kind of didactic part of these lectures is going to be like, is it's going to be pretty short, but I'm going to talk about a common pitfall, and that's that more antibiotics is better. So commonly, one of the rationales we see with the choice of double coverage, and that's double coverage with gram-negative agents oftentimes and fluoroquinolones, and like we saw with this patient, double anaerobic coverage, is that more antibiotic will kill it faster. So twice the number of antibiotics will kill this bacteria faster. And that's not actually been shown to be the case in most cases of antibiotics, especially with straightforward infections. So the coverage of these agents is almost exactly identical. So metronidazole has great anaerobic coverage, but you know what? So does meropenem, so does Piptazo, so does ampicillin sulbactam. They cover all the common anaerobic species, and they're all cidal to all the common anaerobic, almost all the common anaerobic species, which makes them essential. And these anaerobes are very, very sensitive to them, which means that you don't need that much antibiotic to kill off the bacteria. Now, the bacteria have lots of other ways of causing damage. In particular, they produce toxins. They produce, they can be in the context of literal gut content spillage. So the patient may not get better, but it's not because they don't have not enough antibiotic coverage. Gram-negatives is a little bit more of a nuanced story, but Piptazo for this patient, piperacillin tazobactam and cefepime have almost the same coverage for all the sort of gut gram-negative organisms as meropenem, and it doesn't require the use of a carbapenem, which you don't want to use, because what a use of a carbapenem will do is encourage the growth of things like MDRO, Pseudomonas aeruginosa. So in a patient who doesn't need it, use of cefepime and Piptazo is probably safer for the patient and other patients in that context. So going back to this pitfall of more is better, so when you combine antibiotics, there is, though this is in vitro data and not in vivo data, there is a strong possibility that you may actually make each individual's antibiotic function worse. So when you combine beta-lactams and fluoroquinolones, well, blue is antagonism. That means that the antibiotics work against each other, and they are all these combinations are antagonistic. And honestly, if you look at this map, so this is from a paper by Ocampo in 2014, but if you look at this map, most of the combinations are antagonistic, so, and not synergistic. So this is something to keep in mind, and this is, and if anybody wants this paper, we can definitely share that as well. And then there's the other consideration, which is that more antibiotics increases risk to the patient. So just looking at you know, the foe that we are constantly worried about, Clostridium difficile, just the gross number of antibiotics you receive increases your risk of C. diff. So this is the number of antibiotics that the patients received on the bottom axis, and then the C. diff hazard ratio, or how likely they are to develop C. diff, is on the left. And what you see is every time you increase the number of antibiotics, just the flat number, not the amount of over time, you increase the hazard ratio of C. diff by at least 1.5. And honestly, when you get to greater than 5, you're at a very high risk. Some of these patients may be just because they, you know, got round and round and round of antibiotics. But this is something to bring up with your physicians, is that, you know, the more antibiotics they give, the more likely that patient is to come back with C. diff. So trying to keep it to the lower limit of what they need to give is a safety issue for your patients. So I'd like to open this up to questions on the case. And if we could open up the audio so that people can voice questions as well, that would be good. I know some people just don't like using these question systems, but you know, sometimes it's also easier to think out your question and write it down, or just chat it out. So Megan, would you be able to do that?
Hi, yeah, I will gladly unmute. So just as a reminder, that means all the attendees, you will have access to speak through your audio. If you've got a lot of background noise going on, you might just mute yourself if you're not going to be speaking out, just so there's not a lot of feedback for others. Okay, we are just about ready. We have to unmute one at a time. So if there's a lot of background noise where you are, you may need to mute yourself. I see a few of you have done that. Okay, so that was the last one. So all attendees are unmuted. If you have background noise, you might mute yourself, please. That way the other attendees can still listen.
Sure. If you're a non-physician, what's the best way to approach the doctor who prescribed this combination. Erin, are you on the, can we unmute Erin? And this, by the way, was a physician who did that. It wasn't an MD steward.
Hi, this is Erin. Can you hear me?
Yeah, we can hear you.
Hi. So the way to approach the physician is a pretty personal thing. Obviously, confrontation is not desirable. So I always, it depends on the relationship I have with a physician. I think developing relationships with the physicians you're going to be intervening with is really important. I always start out sort of just with a question. Did you realize that you've prescribed double coverage here? I find, especially with the younger doctors, if you're working in a place where there are residents, they might not even have realized it. It becomes an educational opportunity. With a more experienced physician, it might just, be, did you mean to do this? I noticed that these two were prescribed, and I see that there's some double coverage happening here. Did you intend to do this, or what was the reason? And sort of trying to provoke them to think about it and have to justify it to you. It's never good to just go up and say, this doesn't look right, or I think this is wrong. Why did you do this? That's probably not the best approach, but sort of starting out with questions to try to get them to think about it and justify it to you was sort of always what worked best for me. I don't know if that helps at all.
And I want to say that from the physician side of stewardship, we do the same thing. It's not like we go there and we're like, we're physicians, we know better than you. That's a great way to basically shoot yourself in the foot.
Yeah.
It's always a conversation and always a relationship that you're trying to build with the physician or the other provider. So sometimes it's not a physician who's made the antimicrobial order. So it's always a chance for teaching. And I think that's something that, the longer you're in stewardship, the more it becomes helpful to think of it as a teaching opportunity and not a, trying to block usage. So I'm going to go to that additional question. Thanks, Erin, by the way. I'm going to go to the next question, which is, would you recommend a vancomycin loading dose to this patient? And for those who aren't aware of what a vancomycin loading dose is, so the standard dose, dosing of vancomycin is 15 milligrams per kilogram generally, at an interval specified by the patient's renal function. But some institutions use what's called a loading dose, which is, I think, mostly 20 milligrams per kilogram ideal body weight. Now, I don't know. So the rationale for the use of a vancomycin loading dose is you want to get vancomycin concentration in the body up fast. And so the only time I would generally recommend it is if a person is clearly has a fulminant infection and really needs a kill right away with an organism you're pretty certain is vancomycin, only susceptible to vancomycin. So like if they are septic from MRSA bacteremia, or you're pretty certain they have MRSA bacteremia, that might be a good thing. But the one big concern with vancomycin loading dosing is the renal injury, is the risk of nephrotoxicity from vancomycin. And I think there has been some data, at least anecdotal, that it increases the risk of vancomycin nephrotoxicity early on in the course. You don't keep going with vancomycin 20 milligrams per kilogram. You only use that for the first dose or so. But the problem is the patients you often use them on are already hemodynamically unstable. Their kidney function may not be stable. So if you're basically kicking them again with additional vancomycin, and I'm not sure everyone really is comfortable with that. I will say that at our organization, or at least most of the organizations I know, vancomycin loading is generally not done. Any other questions before we go on towards the end of the conference? And so this is what we're going to basically be doing, is we're going to be trying to identify, does anybody have a case they would like to volunteer? We may not have enough time for this. I didn't know how long we were going.
Pepper didn't like.
Oh, somebody may have to mute.
Show a favoritism. I don't know, maybe.
So not right now. And apologies, I may just skip this because we only have 10 minutes, or actually less than that, to go. And I want to be able to get to the end of the conference. But just realize this is the kind of template we're going to be talking about. Of course, it's going to be censored from the place and the patient, unless unless you're willing to discuss it in the context of your hospital. But I don't expect that in any way. So thank you guys all for coming to our introductory kickoff webinar. I think we're going to try to keep the case conferences to between 30 and 45 minutes. That's just a general goal. I'd like to put out a special thanks to the Missouri Department of Health and Senior Services, without which I don't think we would be able to do this. In particular, the state epidemiologist, George Teraplizzi, has been incredibly involved and sort of very has been promoting this activity for quite some time. The state, just so everybody knows, the Department of Health and Senior Services is putting out a survey of people's stewardship programs, and I strongly recommend that people respond to that survey as truthfully as possible, because what the state is trying to do is identify the pain points for hospitals and figure out where they can, throw their weight around to hopefully improve things. I'd also like to call out the Missouri Hospital Association, and especially Allison Williams and Megan, who's on the call today, who've been really helpful in getting this all coordinated and getting everybody on the call. And I think this is this is a new thing for everybody, but hopefully this is going to be very fruitful. So what we'll do is we'll see everybody next time. And if people could, I'm going to leave this conference feedback poll up. And it's basically, the standard questions. Did we do a good job? If we didn't, please tell us. I don't want to ramble on if it's not helpful to people. And also at the end, there's ability for you to give feedback, long feedback, and also recommend additional topics. So it's only 7 questions. Hopefully it shouldn't be a particular burden. We're going to be having feedback questions like this at various points throughout the conferences. So just, get used to answering them if you can. We very much appreciate and would be helped by your responses. So thanks again, everybody, for being involved, and you'll be hearing again from us shortly on the next webinars coming up, and we'll try to focus on small community settings, because it sounds like that's really where the pain is, which we kind of expected. So that's great. You'll be hearing from us, and we can hear from you. So remember the Mo Stewardship email to just send us any questions or thoughts our way. We're happy to help where we can. Thanks, everybody, and I hope you guys have a happy Friday the 13th, and that nothing terrifying happens to anybody. All right. That's it. Thanks, everybody.
All right, thank you. And just as one final reminder, this is Megan from the Missouri Hospital Association. If there were several individuals listening on the call with you, I just ask that you would send their name to me so that we can make sure we get an accurate account for all of our attendees today. And my email address is mgriffith@mhanet.com. Thanks, everybody.